You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 17th, 2025. This week, some listener feedback, another knock against the antiplatelet anticoagulation combination, polypills in heart failure, the physical exam of the future, and the problem of underpowered trials and even a Bayesian analysis cannot rescue. First listener feedback is I received an email from a young colleague in Italy who wondered about my comments last week on low molecular weight heparin for patients with AFib. I remarked about how aggravating it is that hospital doctors give heparin, or low molecular weight heparin, acutely for AFib. It's aggravating because it's utterly non-evidence-based. Not a single trial has ever studied the acute administration of sub-Q or IV anticoagulation for atrial fibrillation. My colleague wrote, quote, I've seen many expert colleagues giving it temporarily for 1 day or two to patients coming to the ED with a new diagnosis of AFib before switching to a DOAC. I don't really understand the reason why they don't just give the DOAC since day one, which of course is exactly correct. I mean, enoxaparin is dosed every 12 hours, and so is apixaban. If you want to anticoagulate the patient with AF, why not just start them on the pill, which will be used long term? To me, the use of heparin or enoxaparin, the habit of doing these things, is kind of a marker for slow thinking. Furthermore, the notion that people with AFib are at massive risk for stroke at the moment they present is also not evidence-based. Yes, AFib definitely increases the risk of stroke over months and years, not hours. In fact, I will cite the famous TREND study, which provocatively showed an extremely poor temporal relationship with AFib episodes and stroke, meaning that patients with AFib have a higher risk of stroke, but most strokes do not occur during or after the AFib episode. This observation seriously weakens the argument for giving urgent or emergent anticoagulation with heparin or low molecular weight heparin. The second listener feedback was on the use of GLP-1 drugs in patients with HFrEF. I talked about that last week. One colleague noted that the previous small studies, which don't really show promise for this drug class in patients with HFrEF, were done before SGLT2 use was common in these patients. This writer thought that might make a difference, as there has been some observational data in patients with obesity and diabetes where the combination of the two was associated with better outcomes. My thoughts, of course, is we wait for larger trials, but I doubt the use of SGLT2 will make much difference either way. That said, my friends, I still have trouble believing that a patient with ischemic cardiomyopathy, EF 30%, previous MI, and severe obesity would not benefit from serious weight loss from GLP-1 agonists, but we shall see. The third listener feedback I was very pleased to get. It came from my co-author of our textbook that we wrote together called EP Testing, and this was Rich Fogaros, who wrote that he was concerned regarding the use of PFA for posterior wall isolation, which I mentioned last week, in regard to a case series of patients who had PFA, posterior wall isolation, that was completely not durable. These patients had repeat study and all had reconnection of the posterior wall. Dr. Rich noted that PFA can cause a dose-related hemolysis, which for routine PVI only very rarely produces any kidney issues. However, clinically significant hemolysis might occur if the procedure is significantly extended, meaning more PFA. Of course, he's right, but I would add that hemolysis noted in earlier studies is surely related to excess ablation that's not in contact with the heart. I think of this of just electroshock therapy to red blood cells. Now, I also note, with limited evidence, that hemolysis may be a product-dependent phenomenon. We have done over 300 cases of PFA with a different PFA system that was initially studied, and we have seen zero issues with hemolysis. I have also not seen much data on hemolysis from other PFA systems. So as always, I thank you for these listener comments. I always learn from them, and thank you very much. Keep it up. So the first topic today is another knock against the antiplatelet anticoagulation combination. One of the most important trials of 2025 was the French aquatic trial of aspirin plus anticoagulation versus placebo plus anticoagulation. In other words, dual versus single pathway antithrombotics for patients who had known chronic coronary disease and an anticoagulation indication, most often AFib. The aquatic trial clearly found that single pathway anticoagulation alone was superior both in efficacy, that is the reduction of ischemic events, and safety. I probably cite aquatic trial multiple times weekly in my clinic when stopping aspirin in this type of patient. But aquatic is actually a primary prevention trial. What about secondary prevention? For example, when a patient on anticoagulation for AFib has an actual ischemic stroke, and that patient also has atherosclerosis, either in the brain or neck. Now, surely this sort of patient should benefit from antiplatelets for the vascular disease added to anticoagulation for the AFib. Well, not so much. JAMA Neurology has published a pragmatic RCT called the ATIS-NVAF, or that's ATIS-NVAF, trial of antiplatelets, clinician's choice, could be anything, and anticoagulation versus anticoagulation alone in patients who had recurrent ischemic stroke or TIA and the presence of intracranial or carotid vascular atherosclerosis or lacunar stroke and AF. Now think about these patients. No matter the cause of stroke, they are enhanced to have reasons to take antiplatelets given the presence of brain and neck atherosclerosis or lacunar stroke. This was a multi-center trial conducted in 41 sites in Japan, average age 77, 29% female, about a quarter had carotid disease, a quarter had intracranial disease, and half had lacunar strokes. The anticoagulation was with DOACs in more than 90%. The antiplatelet drugs, if randomized to dual pathway arm, was 52% aspirin, 31% clopidogrel, and 17% silostazol. Just under 160 patients per arm, so not that many patients per arm. A primary endpoint of either an ischemic cardiovascular event, now that could be CV death, stroke, MI, systemic embolism, or any ischemic event requiring urgent revascularization, or major bleeding. So both ischemic cardiovascular event and major bleeding occurred in 17.8% in the dual arm versus 19.6% in the monotherapy arm. That hazard ratio was 0.91. Confidence intervals went from 0.53 to 1.55, p-value calculated at 0.6. So clearly not significant, and the trial was terminated early at an interim analysis for futility. So when you break down the results to ischemic cardiovascular events, this was 11.1 versus 14.2%. So the antiplatelets actually did lower the thrombotic hazard, 0.76, but again, confidence intervals were wide from 0.39 to 1.48, p-value 0.4. And major and clinically relevant non-major bleeding occurred in 19.5% versus 8.6. 19.5 versus 8.6. That's a hazard ratio of 2.4, confidence intervals from 1.2 to 4.8. And that's a highly significant p-value for increased bleeding on the combination therapy. And the authors concluded that in this first RCT evaluating secondary prevention in patients with ischemic stroke and concurrent non-valvular AFib and atherosclerotic vascular disease, no significant difference in net clinical benefit was observed between oral anticoagulation monotherapy and combination therapy with an added antiplatelet agent. However, combination therapy was associated with an increased major and clinically relevant non-major bleeding. So my comments, this top-line finding goes along with nearly every dual versus single pathway trial. The authors enhanced the patient population here to a group you'd think could benefit from the combination. These were post-stroke patients with serious atherosclerosis above the shoulders and atrial fibrillation. So the findings, if accepted, go against the common practice when atherosclerosis is found in a post-stroke patient on oral anticoagulation. That is, you, me, we commonly see neurologists recommend adding an aspirin to an anticoagulation combination. So that these top-line findings of the ATTIS non-valve AFib refute this finding. And of course, our Bayesian priors here, which should be extremely pessimistic given the previous trials, right? AFIRE, EPIC CAD, and now Aquatic, they all show harm or no benefit from the combination. So that if you add that to the findings of this, it even strengthens our posterior belief of these findings. But, and of course there is a but here, like so many clinical trials these days, there's a lot of uncertainty, which was likely made worse with early termination of the trial. Ischemic events were 11.4% versus 14.2% in favor of the combination. That's a 24% relative risk reduction and an absolute risk reduction of 2.8%. And if you do NNT, that's an NNT of 35. That seems like a pretty big effect size. The problem, and the reason this nearly 3% absolute risk reduction is declared not significantly lower, is that the 95% confidence interval span from 0.39 to 1.48. In other words, the true effect could have been 61% better or 48% worse with the combination, and that's a huge spread. So I'm actually not sure we can declare no difference here with any confidence. Ischemic events were lower, and that is the direction you'd expect them to be, given that every patient had documented vascular disease in the carotids or the brain. And that's a different direction than Aquatic went. Aquatic was surprisingly showed higher rates of thrombotic events in the aspirin anticoagulation arm. So you could argue perhaps if more patients in this trial were recruited and event rates were higher, you might see the confidence intervals around that 24% relative reduction in ischemic events. You might see it get tighter. Well, you might not. You just don't know. What we can say from this trial, though, is that bleeding rates are higher. The point estimate was 2.4x higher, and the 95% confidence intervals allowed for it to be nearly 5 times higher. So you'd have to have a whopping, highly confident, statistically robust reduction in ischemic events to justify a greater than 2 times risk of major bleeding. So I think we can conclude that the routine addition of antiplatelets to anticoagulation in post-stroke patients like those enrolled in the ATTIS non-valve AFib trial is not justified. Now, whether there are unusual patients who have a super high risk of vascular stroke and lower risk of bleeding, I don't know. I think you could make a case that this trial does not preclude patients who might get a net benefit, but these would be likely few and far between. Ideally, though, this data would lead to another confirmatory trial in another geographic area. But gosh, the routine use of aspirin or antiplatelets to anticoagulation in ischemic stroke in patients with vascular disease is common, and here's another trial that surprises us. All right, next topic is Polypill for HFrEF. The journal JACC Advances has published a paper that delves into the possibility of a polypill for patients who have HFrEF. It's an intriguing and bold proposition, not least because for most people, taking all these guideline-directed medical therapy pills is a buzzkill. Remember, folks, the goal of treating people is to improve outcomes with minimal disruption to their life, because patients aren't just patients, they want to live life. When we treat patients with heart failure, our focus, the doctor's focus, is implementation, as in take these medicines, then come into clinic, and we can adjust the medicines, then come into clinic again, and then take different doses, which means going to the pharmacy with different prescriptions, parking at the pharmacy, dealing with insurance companies, paying money. A patient who is a person has other things to focus on besides being a patient, like I said, living their life. A polypill with everything in it would be a tour de force in minimally disruptive care. One pill for all those things. That would be amazing. And polypills have some serious promise in treating hypertension and cardiovascular prevention. But, combining 5 milligrams of amlodipine, 5 milligrams of lisinopril, and 12.5 of HCTZ is easy compared to combining the 4 classes of guideline-directed medical therapy. The authors of this paper interviewed 9 patients and 22 healthcare providers, and they created a framework on how this would work. Their paper has super complex tables and graphs, which I would propose are the main arguments against this idea. Now, I've been initially negative on cardiovascular prevention and hypertension polypills, and I've come around to be far more open about polypills for these indications. But I think polypills for HFrEF is going to be destined to fail. A, HFrEF is too complex a condition. B, patients are too varied. C, guideline-directed medical therapy might suffer from at least a partial reverse causation. Hear me out on this. We mistake causality, I think, at least somewhat, with guideline-directed medical therapy. We think taking all the pillars of guideline-directed medical therapy causes better outcomes. And it does within the confines of a trial, a careful trial, with highly selected patients. Equally likely, though, is that the ability and the drive to fill all these prescriptions and swallow 4 different drugs may be a marker for patients who will do well anyways. And if that is the case, a polypill is a solution to a problem that does not really exist. D, when patients have side effects to an ACE inhibitor or MRA or beta blocker that have been started sequentially, it's an easy problem to solve, but it's not so easy to solve adverse effects from a polypill. Anyways, I'm interested in your thoughts on the possibility of polypills for heart failure. All right, next topic is the physical exam of the future. Young listeners don't know this, but older doctors worry about becoming relics. We do. Yes, we do enjoy the experience of having seen something so many times that you walk into a room and you can recognize a situation in nanoseconds. That's a nice thing about being old. But a downside of getting older, besides a lot lower watt output on the bike, is that you can get stuck in old thinking. For instance, I'm embarrassed about how long it took me to adopt point-of-care ultrasound to access femoral veins in the EP lab. I would never stick a central vein now without ultrasound, but it took me too long to adopt this technology. Jack Heartfailure has a short paper from a group in Dallas who came up with a simple 4-stage classification to estimate right atrial pressure with an ultrasound. It's a JVD assessment in 2025. Basically, this point-of-care ultrasound is used to assess the internal jugular vein size relative to the carotid. They do it supine at 45 degrees and at 60 to 90 degrees. As the head is lifted, normal RA pressure would have the IJ be smaller than the carotid artery, but as pressure increases, the IJ is bigger and bigger, and they have an algorithm for it. And their C statistic was decent, and their positive predictive value was decent. Surely this is as good or better than looking at the jugular veins and just saying, oh, there's JVD there. Now, I don't have many comments about the paper or the algorithm other than the doctor of the future won't be examining people with a stethoscope and doing JVD. It'll be an ultrasound, and I think that is cool and really cool. 2025 is kind of a strange place in medicine, isn't it? Not only is the physical exam being transformed by handheld ultrasound, but what about large language models and AI? This is also going to transform our ability to make differential diagnoses and formulate treatment plans. I can't tell you how much I look forward to the day when a patient who's referred for cath after a positive stress test asks the doctor why they are doing that, given the obvious results of the COURAGE trial and the ischemia trial. They know this because they put it into Claude or ChatGPT, and ChatGPT said, why are you doing this? Because the ischemia trial would suggest no difference in outcomes. Why don't you just do conservative therapy? All right, final topic today is a story about underpowered trials. The clinical question that we're going to use to discuss trials and analyses of trials is the optimal anesthetic strategy for patients having endovascular therapy for ischemic stroke from a large vessel occlusion. And I know you aren't an invasive radiologist, and neither am I, and that's not the point. I show you this trial, which is in JAMA Neurology, as an example of how the analysis of RCTs can be problematic. The two anesthetic choices are general anesthesia or moderate sedation. The randomization was good, 1-to-1. The primary outcome was the ordinal modified ranking scale, which is a 6-point scale. 0 is no symptoms, 1 is no significant disability, 2 is slight disability, 3 is moderate disability, requires some help but can walk unassisted. 4 is moderate severe disability, can't walk. Severe disability is bedridden, incontinent, requires constant care, and 6 is dead. The trialists report that 1,931 patients were screened and 1,671 were excluded, and they randomized 260 patients, and we should pause there. It's really good that the authors described how many were screened and excluded. Many trials don't do this, and it's important to look at this as a consumer of evidence. You want to know how selected the patients are in a trial. Here, it is very selective. 86% of patients were excluded. Now, no one reason for exclusion dominated. Sometimes it was the patient was intubated, sometimes it was stroke location, the onset of stroke symptoms, the NIHSS score, and age. These are all reasons for exclusion. Screen to randomized is a huge issue for users of evidence. The classic AFib trial where this came up is the CASTLE-AF trial. CASTLE-AF was AF ablation versus antiarrhythmic drugs and heart failure. And while AF ablation looked great in CASTLE-AF, more than 3,000 patients were screened to enroll 300. It was the same situation with danger shock trial of Impella versus standard care in patients with cardiogenic shock from MI. The trial took 10 years, screened 1,200 patients, and enrolled 360 patients. My interventionalist friends have long said that some people don't get out of the lab alive without an LV assist device, and danger shock confirmed this idea. But it took 10 years to find these patients, so it's a highly selected group. And none of this is bad, but when screened is far greater than enrolled, it tells you to be super careful when you translate this evidence to the bedside. Now, back to the SEGA trial, SEGA trial of GA versus moderate sedation. A novel feature of this trial design was the use of Bayesian analysis, and here they wanted to have an 80% power to detect superiority of general anesthesia over sedation. Bayesian analyses are fun, aren't they? Instead of testing how surprising the data is, if you start with the idea that there is no difference, i.e. the null hypothesis, a Bayesian analysis gives you an estimate of the probability of treatment benefit and harm given the data. You not only get the probability that a treatment is better by any amount, you can estimate the probability that is 5% better, or 10% better, or 20% better. Finally, Bayesian analysis can combine previous data to influence the current data. This occurs by creating probability density functions and then combining them. That is, the probability density function of the prior belief, and you can input hazard ratios from previous trials, and then you combine that probability density curve with the current data, and then you get a posterior curve. And of course, you need a computer and calculus to do this, but computers can do it. But the key concept is not the calculus or the curves. The key concept is that a trial gives you data that influences your prior belief. It doesn't give you an answer. It just makes you more or less confident in your prior belief, just like a medical test. Now, for this trial, the authors had little pretrial data, so they used non-informative priors. And the results were that at 90 days, a shift in the distribution of the ordinal modified ranking scale was found favoring general anesthesia. The odds ratio was 1.2. The 95% credible intervals, however, went from 0.79 to 1.87. That kicks out an 81% posterior probability that GA was superior. They also looked at functional independence, which is manifested by a modified ranking scale of anywhere from 0 to 2. And this was more likely to occur in the GA group, and the relative risk here was similar, 1.2, 20% higher. And the credible intervals went from 0.9 to 1.65, so the probability that GA was better was a little higher at 89%. Successful reperfusions were very similar, 97 versus 95%. Symptomatic intracranial hemorrhage was 0.8. This was one patient in GA versus 2.4% or 3 in sedation, with posterior probability that GA was superior to sedation of only 72%. Now, one concern was that there was a slightly higher incidence of in-hospital mortality in the GA group. That's 8.5% versus 7.0%. That's an absolute risk increase of 1.6%, and curiously, the authors don't provide a probability analysis there. So the authors concluded this randomized trial found that patients with large vessel occlusion, acute ischemic stroke, who were treated with endovascular therapy using GA, general anesthesia, had improved rates of 90-day outcomes and higher rates of successful reperfusion compared with those treated with moderate sedation. And I saw on Twitter that everybody was saying GA was better. So my comments. I'm not sure that people on Twitter were right, but let's leave that for a second. First, let's just talk about Bayesian statistics, because I love Bayesian statistics, because you want to know as a clinician the probability that the treatment being used is better than its comparator. Then, of course, you want to know the probability that it meets the clinically important difference. For instance, to use a new drug, one that costs more, or maybe one that has more side effects, you want it to be 10 or 20 or 30% better than the old standby. I mean, you don't care if the probability is 90% that the new therapy is 1% better. You want to know the probability that it's better than some minimally important difference that has to be determined by experts. For instance, consider if finerenone was ever compared to spironolactone in HFrEF. Now, it wasn't, I think by design, of course, but if it were, you would not care about the probability that finerenone was better than spironolactone by 1%, say odds ratio greater than 1.0, you'd want to know that the probability that it was 20 or 30% better to justify the extra cost. And that's my criticism of this trial. They declare that general anesthesia is the winner, but it's only an 80% probability that the odds ratio is 1.0 or greater. I mean, that means there's a 1 in 5 chance that it's worse, odds ratio less than 1.0. I don't know why they wouldn't declare a minimally important difference and then tell us the probability that GA met that standard. Why? Because GA is more resource dependent, right? Hospital death was higher. It could be chance, but they could have told us the probability here, but they did not. I mean, you need an extra anesthesiologist, you need people. So you'd want GA to be some degree better, not just 1% better. I don't know what the minimally important difference is in this situation, but it has to be greater than just 1.0. I mean, perhaps it's 10% better. And the second issue with this trial is, when is 80% probability good enough? It seems to me that we would want it to be higher. Many Bayesian trials use a 95% probability of any benefit. What's more, if you accept an 80% probability of benefit, then you have to accept a 20% chance or 1 in 5 chance of harm. And when you look at the probability density function curves in this paper, you see there's about a 5 to 8% probability that the odds ratio for harm was more than 20%, or odds ratio less than 0.8. Now, consider a comparison to the sacubitril valsartan situation in HFrEF, right? In Paragon HF, sacubitril valsartan versus valsartan led to a 13% relative risk reduction in the primary endpoint of total hospitalizations for heart failure or CV death. So this 0.87 hazard ratio had 95% confidence intervals from 0.75 to 1.01. That p-value calculated at 0.06. So they used regular frequentist statistics, so the 13% lower rate of the primary endpoint was not surprising enough given the assumption of no difference, so it was declared in the conclusions of Paragon HF that sacubitril valsartan did not result in a significantly lower rate of the primary outcome. But Jay Brophy, who's a Bayesian expert from McGill University, he's published an analysis of trials and found, and I'll link to this analysis, he found that the probability of a relative risk reduction less than 1.0 for sacubitril valsartan versus valsartan was 97%. In other words, in Paragon HF, a negative trial by frequentist statistics, there was a 97% chance that sacubitril valsartan led to fewer events. But that's not really what we want to know, right? Paragon was powered to find a 19% lower rate with the new drug. Now, you can assume then that experts must have considered 19% the minimally important clinical difference. And the probability of that, given the results, was only 38%. So that's a pretty low chance that there was a minimally important clinical difference. And this is the kind of analysis I would have liked to seen in this GA versus moderate sedation paper. As an outside observer, I'm not sure that an 80% probability that GA is better than moderate sedation by 1.0 is strong enough. I'm not sure what the minimally important difference here is. And surely, if you say you want GA to be 10 or 20% better, then the probability of that is going to be way less than 80%. In fact, I even thought, what would the frequentist value would have been here? Like if this trial was analyzed via the normal p-value, I bet this data is not that surprising given the assumption of no difference, meaning the p-value would be high. So I had this idea. I said, well, why don't I just put this into AI, put this into Claude? And I asked Claude, given these wide credible intervals, what would your estimated p-value be? And Claude came back and said the p-value would calculate at 0.35 to 0.4, which is what I would have guessed, which would make this squarely a negative trial. So the two take-homes is that I'm not sure that we can make much conclusions about whether GA is better than moderate sedation, and I don't think we should use this trial to change practice patterns for interventional care of acute stroke. And the second thing, of course, is that Bayesian statistics are fun and excellent, and I think they give clinicians a lot of good information, but they can't rescue a trial that has a high degree of uncertainty. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review. These things help others find us. And of course, if you have something to say, contact me. I'm always happy to learn from the comments. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.